Welcome to the Vet Dental Show. I'm Brett Beckman. I'm a board-certified veterinary dentist, and we come to you every week on Wednesday to provide the veterinarian and the technician team some actionable things that you can use in your practice. And this episode is going to be a recorded episode that we've done in the past, not a podcast that we've recorded or not the Vet Dental Show, but actually some other information for you that we know you're going to enjoy. So sit back, enjoy, and we'll see you at the end of the podcast. So Sarah and Amanda first. Let's see, a lot of dogs with worn incisors look fine radiographically, and I can't probe into the canal. So the question is how to handle those. That's a really good question. And that you're indeed right. Many of those have been worn slowly over a long period of time. And the dentin has come in and repaired itself because of that wear being so slow. Some of those dogs are atopic, and so they have skin allergies and they wear those teeth almost to the gum, but they do so by chewing their hair or chewing their skin, and their hair is in the way. And that's kind of like a really fine sandpaper over the years, and those can be either non-vital or they can be perfectly fine. Most of the time, they have tertiary dentin over them where the dentin has sealed those. There's no exposed dentin as we get when we get acute fractures where the enamel's gone and we've got just raw dentin there where the bacteria can get in and eventually get to the pulp. But sometimes they are. Sometimes the wear there is no tertiary dentin there, especially if it's tooth-on-tooth wear, where it's more aggressive, but it still takes time, but it's more aggressive. So you may have exposed dentin, but if you do, you probably have a non-vital tooth. So radiographically and grossly, you need to evaluate that. And tertiary dentin is like enamel. It's very the surface area is very smooth, and so there's not any grasping that occurs if you take a sharp pointed dental elevator and run it over, or dental probe and run it over the surface of that dentin. If it's kind of chalky, then it's not tertiary dentin, and it needs to be sealed with a bonding agent, which most general practices don't have. And so that's a referral, or that's part of getting involved and learning more to the point where you're comfortable doing that and you've had exposure to that as well. So those are the scenarios that you run into, but you always want to radiograph them because many of those can and will be non-vital and they need to have extraction. So I understand that trauma from chewing on hard objects has killed these teeth. That is absolutely right. That will happen quite commonly. They will also fracture. I think I just described would it make it more painful or prone to infection. Prone to infection part, I think we talked about just now. And non-vital teeth, why do we extract them? Well, just from the very reason that I just mentioned, that non-vital tooth, the pulp is going to be necrotic. It may not be bacteria in there, but it's going to get out. It's while it dies, it's painful because there's still a live nerve in there that's inflamed due to that. And then once it gets out in the bone, that's also discomforting. There's nerves there. Bone pain can be very, very painful. So yes, all of those either need a root canal or they need to be extracted. Root canals are done mainly on the bigger teeth. You can do a root canal on a third premolar in the maxilla or the mandible, but we don't recommend that, and I don't know. It's been forever since I've done that. I just don't recommend it. I don't think it's the best thing under the circumstances in most cases. So if it's a big tooth, that's a different story. If it's a functional tooth, canines, premolars, first molars in the mandible, but otherwise no. So good question, Morgan. What I wanted to mention is that when you chart, you have taken into consideration the progression of the best step-by-step as you go from induction to recovery. And Annie covers this in detail in the technician course. Induction to recovery, what do you do first? What do you do second? What do you do third? But for the most part, what we're doing first is we're taking radiographs. And those radiographs are intended to show us the teeth that we know right away that we're going to be extracting. And if we know that we're going to be extracting 10 teeth in there because of the bone loss, we don't need to chart those teeth from a periodontal standpoint. All they need is the periodontal disease index. We don't need pocket depth. We don't need gingival recession. We don't need furcation exposure. You don't need to waste time, the patient's time, doing any of that stuff. The radiographs are give you the designation of periodontal disease 1 through 4, and if it's a 2 to a 4, it may be an indication for extraction, depending on the circumstance. So if you've got that designation on the chart, you don't have to waste your time doing pocket depth, because guess what? When that patient gets that tooth extracted, when it comes back, there's no pocket left. It's gingiva that's healed over that tooth socket. So you're not measuring pockets to see how good your therapy was for those. There's nothing that's going to be there in the future, and you've documented why you've extracted that tooth with the PD index. So that's I wanted to keep that in there because that's an important distinction on charting. And unfortunately, we don't have any charting examples there, but Annie, I'm sure, has plenty in her course. She goes into charting in detail. And guys, let me also say this: when we talk about these courses that we have, I guess the mindset of some might be, we're kind of listening to a marketing conference here. The opposite of that is what's actually happening. If I didn't tell you about our courses and you didn't know about our courses, then you wouldn't have the opportunity to help your patients long term like you can by utilizing that. And I personally, because we have such a valuable resource for you as a general practitioner, I would feel like I'm cheating you by not telling you. It's that important to let you know. If you don't know about it, you're not going to be like the other thousands of people that have taken our courses all over the world that are now benefiting their patients. So I'm not apologizing one bit for talking about our courses, because I know how important they are to all the patients out there, all the pets out there that are benefiting, and all the practitioners that are out there that are benefiting from knowing that they're providing the best that they can provide for those patients. So I just want to put that into perspective for you so that you know where I'm coming from on that. Blake, this is a little further dive into what we talked about before. Good question here. So if you're in general practice, you're probably not doing any bonding to any extent, because you've not been trained in restoration, repair, and cavity prep and all the things that are involved with that. So it's not that it's that difficult, but you just have to know all the concepts, and you have to have a training session where you've had at least one training session where you've had exposure to that and you know what you're doing. So we do have an advanced course. We pretty much just keep that with our IVDI members and our mastermind members. We don't generally open that up to the public, but occasionally we get an opportunity where we could get one more good instructor that knows this material, and we might be able to add some folks. But usually we keep these at 11 people, and so they're a little more expensive than the general things, because we can't get a lot of people in these because there's a lot of moving parts. But we do teach that in that course. But again, if it's available, it'll be on the website. But otherwise, those usually fills with the mastermind people, and we do that every 2 years for them. Steve, thanks for your question. Do you always have patients in dorsal or ventral to come and see to perform extractions where you're visualizing what you're doing the best for that part of the extraction? So let me answer this from that standpoint. As a maxillary fourth premolar, for example. So when I start that procedure, I want to be able to get to that tooth, and I want to be able to make that vertical releasing incision and make my incision in the sulcus back to that first premolar, or that first molar, where I'm not contorted in some way. So the best way for me to do that, if I'm sitting here and this is the dog's head. I want that dog's head out here a little bit, and I want them on their side. I want them in lateral recumbency. And then I'm going to tilt that head down a little bit, and that way I've got the lifted up. I've got a lip speculum on there, many times holding that lip back a little bit. But usually you don't need to do that. And then that way I can make that incision very easily. I can make this incision very easily. And I've got that patient right here. If I'm looking down, I've got it right here, and that tooth is right here. And the crown's pretty much facing, but maybe at a little angle down. So you'll get comfortable knowing when you're removing your neck, or you're doing your next step, which is you're elevating the periosteum and the flap up to get your exposure to the bone. You elevate that with your periosteum. You're going to press down on that periosteal elevator, and this is a mistake a lot of people make that we go over in the labs. You press down on that periosteal elevator hard on the bone, and you're not pushing up. You're not pushing toward the root. You're doing this. Just a little push down and lift. Down and lift. And so you're lifting the gingiva off of the bone, and if you do it that way and your angulation's right, you can press down really hard, and you'll never do this and go up into and mess up your flap or hurt yourself, because many times your hand's up here when you're putting that kind of pressure on there and you're doing your elevation. So that's a little side bonus there as far as technique goes. It's kind of a little thing you think, but it's very critical in successful flaps, and that's why a lot of people have a hard time getting their flaps up and make mistakes and rip them. So that will hopefully help some of you to avoid that. And when I describe that, the reason for that is that you want to be able to have that forward movement as you start to get past the unattached or the attached gingiva, when it gets really easy. So if that tooth's facing you, then you can do this after that attached gingiva is done, because that unattached gingiva is very loosely attached by periosteum to the bone. So you can really go quick by moving up and apical to get the rest of that flap up. If you watch, just go on probably YouTube and watch our fourth upper premolar extraction video, and you'll see what I mean specifically on that.
I hope you enjoyed this episode. There's a lot of actionable items in there that you can take and use in your practice immediately. So put those to work and enjoy the benefits for the practice lifetime in your dentistry service. And if you would, please go to iTunes, leave a rating and review, take a picture of that with your cell phone, and then post it on the Vet Dental Show Facebook page. Just go to Facebook, search Vet Dental Show in the search in the upper left, and the show will come up. And once you post that, we'll send you a free instrument use essentials course. So if you want that free course, again, all you have to do is go to iTunes, leave a rating and review, take a picture of the rating and review with your phone, and then post it on our Facebook page, The Vet Dental Show. So until next week, have a great week. Take care, guys.